I'm an orthopedic surgeon. My dad was an orthopedic surgeon. Some of you guys may know him or know his name because people were always asking me that. And I joined his practice when I got out of residency. I went to Maryland for residency and medical school in 2003. And I worked at Orthopedic Associates, which is out in Howard County, and Howard County and St. Agnes and Kernan Hospital. And then I decided to move to Mercy when he retired in 2006 because I was trying to do this technique for hip replacement that was very gentle, tissue-sparing technique where I could replace the hip without cutting any of the patient's muscles, and it really made sense, and it's remarkable on what the outcome is compared to traditional hip replacement. But I really struggled, even with my dad being the chief of surgery at Kernan at the time. I could not get any the hospitals to buy me the orthopedic table that I needed to do that particular technique. And it's really a drop in the bucket for a hospital. So I got frustrated, and Mercy, it was out of the blue. They called me and heard, hey, we heard you're looking, and it's no problem. Why don't you come down here and talk to us? And so it's worked out great, and that's why I made the transition. But I still live out here. My family's out here, and I wanted to be a part of Howard County still. And when Warren opened up the opportunity for Mercy to have an office, I jumped on it. So I'm right down the hall on Thursdays, and that's been great. I love taking care of all you guys, all my neighbors out here in Howard County. I do general orthopedics, so I do shoulders, hips, knees, carpal tunnels, pretty much the gamut, fractures, some neck fusion work with the neurosurgeon at Mercy. I shy away from foot and ankle now that I am at Mercy because they have a great foot and ankle center, so I refer most of those patients to Dr. Meyerson, Jang, and Campbell and their group. And spine, I've always referred my spine out to my colleagues down at Mercy. And Dr. Park in neurosurgery takes care of the spine, and Dr. Edwards is the orthopedic spine guy at Mercy, who are very good. And I still use Dr. Shin out here sometimes. There's a lot of patients from the old group that still go to Dr. Shin. So that's pretty much it. Shoulder makes up a third of my practice. It's really common. There are tons of people with shoulder pain, as well as knee and hip. And although hip has become a big part of my practice because of this technique, hip is actually one of the least common joints to get arthritic. It's more common in the thumbs and the hand, which I take care of, the shoulders and the knees. So I wanted to cover shoulder pain because there's so many different causes of shoulder pain and techniques to fix it. And there's been a couple advances over the past 5 to 10 years that have made a dramatic difference for patients. And the very last one at the end is called a reverse shoulder replacement. And that's really exciting because that has provided a solution for patients that otherwise didn't have a treatment option available to them. And that's something that's really come about in the last 5 years. And that's a special type of shoulder replacement for patients who have a rotator cuff tear that's not repairable and really bad arthritis of their shoulder. And they're completely debilitated. They can't pick their arm up. And after the surgery, literally the day after surgery, they can put their arm over their head. So it's really awesome. So I want to tell you about that. And also arthroscopic techniques. So the minimally invasive techniques that we do with this scope, with the camera and the instruments that we use through the scope have really advanced over the last decade. And that's really made repairs of the labrum, the biceps tendon, and the rotator cuff much more gentle. It still takes time for those things to heal, so it's not like it's a super fast recovery. Like the hip, you're not waiting for anything to heal. I mean, you replace the joint, it's done, and you just get, once your skin is healed, you're done. Whereas these techniques, even though they're less invasive, which causes less pain and maybe a faster return to a lower level of activity, you're really still at the mercy of God and biology to heal the tendons and the soft tissue back to the bone, and that does take about 6 weeks. So that's really that really hasn't changed all that dramatically, and probably never will because we're at the mercy of biology at that point. But at least we're getting better with our techniques that are causing less pain and less scarring. And I'll go through all of that with you. So I wanted this to be comprehensive, so I put everything in here. And this we could go on forever. But I wanted to touch on everything that could possibly go wrong with this shoulder. And then you guys use me as much as you want as just a free ortho consult. So I don't care what you ask me about anything. It doesn't have to be about the shoulder. Just hit me, or if you want to learn more about any one of these specific problems, then just throw your hand up and ask me. There's a great website that I pulled up on here that has animations. It may be more fun for me just because I do I'll crouch down if you guys can see, so you guys can see. It may be more interesting to me just as a surgeon technique-wise, but if you're interested in really detail of actually what I'm doing, I have little animated videos that are fun to watch at the end. So we'll go through the causes, and with each of the causes of shoulder pain, I'll go through the diagnosis, treatment, outcomes, and what the patient's a typical expectation should be. So these are all the causes, and I lumped the first one in a group because it's the most common one, and they're all sort of related. So bursitis, impingement syndrome, rotator cuff tendonitis, there's kind of one group, and that's the most common. Then there's calcific rotator cuff tendonitis, biceps tendonitis, partial and full rotator cuff tears, labral tears, frozen shoulder, instability, chondromalacia, which is a fancy word for early arthritis, and a cuff tear arthropathy, which is that problem that I told you about with the reverse shoulder replacement. We'll save that for the end. So this is a good picture of the anatomy of the shoulder, and just going through this briefly, I'll point out all the anatomical landmarks, and then we can refer back to this as we go through the talk about where the problems occur with each one of these particular areas. So this is looking at a patient front on. This is the left shoulder. This is the collarbone. This is the acromion bone and the coracoid bone, which are part of the scapula. These are important ligaments right here, and right here. This purple represents the bursa, which is a sac of fluid on top of the rotator cuff, which cushions it between itself and this acromion bone and this acromial arch, we call it. This red right here represents the rotator cuff muscle. This is the biceps tendon as it goes inside of the shoulder right here. You guys can see the arrow. And the white on the end of the bone is the cartilage, and that's what wears down when you get an arthritic shoulder. And this here depicts, although a cutaway version of it, this is the capsule of the shoulder, which can also become pathologic, and that is what holds the joint fluid in. So first, for the impingement syndrome and bursitis, we diagnose it with history, physical exam, x-rays, and MRI. And with the history, it's usually not traumatic, but it can be stimulated by a trauma. And patients typically report pain with overhead activities like reaching up to put a dish away or reaching out to grab something. They get a sharp pain in the front of the shoulder and down the side of the arm. And typically they have trouble sleeping. If they sleep with your arms over your head, it really can exacerbate this problem, and patients will complain that they have trouble getting their arm down when they wake up in the morning. On physical exam, there's these Neer and Hopkins impingement tests which we do. And what they are is basically stimulating that. So I pick the patient's arm up and just like this, and they complain of pain right here. And that's the supraspinatus tendon. That's the front tendon in the rotator cuff that's banging into the acromion bone, causing that pain. So this is simply the Neer impingement test. The Hopkins one is for the infraspinatus, which is one tendon further back. And to do that test, I just bring the patient's arm like this and internally rotate, and that brings that infraspinatus muscle into the acromion. And that's the typical finding for somebody who has infraspinatus involvement. X-rays are typically normal with this. There is a acromion morphology that we look at, which is the shape of that acromion bone.